more or
Open.
right? Okay. Do you want me to start, Sri?
Yes, sir. We'll proceed, sir.
Okay, thank you very much. Well, it's a great evening for us today because our invited guest speaker today is Professor Pazhani, and we have been very fortunate to have his presence here today as the guest speaker on a niche topic, which we'll come to in a minute. We also have Pushkar Pazhani, our Gen Z new neurologist for the future for Viksit Bharat, presenting a case. And first of all, the topic is very novel, but very relevant. And there aren't many people that I know of in the whole of Bharat who have the medical legal licensing and to be able to speak with authority than Dr. Pazani and possibly less than 10 people in the whole country, from what I know. So I think this will be a great initiative to encourage our next generation of neurologists to take up medical legal practice in neurology and in the neurosciences to a greater degree, and that will help the development of confidence in sort of approved clinical care. Will build up confidence in the patients that they're getting the right treatment, and at the same time, when we have more experts from our fold, we can advise the courts, the judges, including Supreme Court judges, better to understand the nuts and bolts of very complex technical things in neurology and all aspects of medicine. And so far, I've seen only very scrappy, injury reports issued by CMOH and things, which mean nothing at all when those cases come to court. So I think it's a great initiative that IN Critical Care Subsection has had the pleasure and the privilege of having Dr. Pazhani, looking at patient care, looking at the confidence of practicing clinicians across Bharat to be able to realize that if things go wrong, there'll be somebody to defend what is defendable. And I'm sure we'll be told what is good practice in clinical neurology and all aspects of medicine and neurology. So that's a great warm up to our Gen Z scholars who will be the leaders of the future. So that's one thing. And I am very privileged to have the very top brass of the IN neurology. And I was very happy to see our president, our president, Dr. Lakshmi, our treasurer, Dr. Meenakshi, being sent out the invite links. But also, we have the privilege, hopefully, if they can find time to join the meeting, we'll have our ex-president, Sangeeta Rawat, our president-to-be, Sudhir Kothari, and Devashish Chaudhary, and many others among the fold. Hopefully, they all have come to hear Professor Pazhani. So I will not stand anymore between Professor Pazhani and you and hand over the microphone unless Dr. Sri wants to say anything more to Dr. Pazhani.
Thank you very much, Dr. Pathare, Dr. Srivartan. I thank the Critical Care Neurology Subsection of Indian Academy of Neurology for the invitation. I thank the Indian Academy of Neurology for the opportunity. So the topic given to me is on medical legal issues in critical care neurology. And subsequently, Dr. Pushkar Pazhani will be presenting an interesting case of neurovascular intervention. I'll start my talk. I'll share my slides now. Can you see my slides? Okay.
Yes.
Yes, we can, but it needs to be in slide.
Okay, thank you very much. So it is a quite vast topic. If I talk too much, it will be very boring. So what I have made is the important topics I have covered with some illustrations, so that will be more interesting, like some case studies. So today's topic is on medical legal issues in critical care neurology. So everything revolves around a term called negligence. Negligence is not there in only medical negligence. There is negligence in different field, in different forms. So how this word is formed and what is the source of this word actually? There is an interesting case in 1856 between Blyth and Birmingham Waterworks Company. The defendants had installed water mains along the street with hydrants located at various points. One of the hydrants across from plaintiff's house developed a leak, as a result of exceedingly cold temperature and caused water damage to the house. The plaintiff sued for negligence. The omission to do something which a reasonable man, guided upon those considerations which ordinarily regulate the conduct of human affairs, would do or doing something that a prudent or a reasonable man would not do. So this is the definition of negligence they given at the time, and subsequently, this word is used everywhere. So then there is another interesting case in 1932, the Donog and Stevenson case. On August 26, 1928, Mrs. Donog's friend brought her a ginger beer from Wellmeadow Cave in Paisley. She consumed about half of the bottle, which was made of dark opaque glass, so she could not see what is inside the glass. When the remainder of the content was poured into the tumbler, at that point, the decomposed remains of a snail floated out, causing her alleged shock and severe gastroenteritis. So in this case of Donog and Stevenson, judgment was made in favor of Mrs. Donog. The House of Lords concluded that Mr. Stevenson, the ginger beer manufacturer, bore a duty of care towards Mrs. Donog, notwithstanding the absence of a direct contractual relationship between them. There is no direct contract, but they found it is a case of negligence. This is another interesting case, which is, these are all cases quoted in the law textbooks about negligence. Then there is a case in Connecticut, there is a Cross versus Guthrie. A husband sued a surgeon who performed a negligent and fatal mastectomy on his wife. The court found in favor of the plaintiff, establishing a foundational US precedent that doctors must execute their duties with a reasonable skill and safety. We think that maybe these negligence, medical negligence are going on for quite some time, but these are all there from Mesopotamia era itself, thousands of years back. And the people don't know the skill and do improper procedure. And there are documentation about cutting off the hands, and there are incidents of talking about negligence in our books on medical treatment in the ancient time. So these are all words used in long time back itself. But these are legal terminologies started used from the past 2 to 3 centuries period. The first case in UK was Bransby Cooper versus Stephen Pollard case in 1828, widely cited as the first formally recorded and highly publicized medical malpractice trial involving a lithotomy surgery, that is bladder stone removal, that led to the patient's death. It will be very sad to see that in the olden days, when the anesthesia technique is not well developed and the process was done with not much anesthesia or not without anesthesia, and it was very the story itself is very disturbing, though how people managed and made the people to get healed, but a lot of risk involved at the time. And this was a famous Dr. Cooper, Mr. Cooper, and this was a lithotomy case. And he put a defamation suit on the patient, and for some £1,000, something like that. And he got a compensation, £100. Meagerly was able to win the case. And that was the first recorded case in the medical negligence those days. So then there is an interesting case on Bolam and Freen Hospital Management Committee case. This is called Bolam test. This is the basic of this medical negligence terminology developed over a period of time. So this is an interesting case in 1957. It's a landmark English tort law case that established the Bolam test, the foundational legal standard for determining the medical negligence. The patient, John Nectar Bolam, a psychiatric patient, undergoing electroconvulsive therapy at Freen Hospital for severe depression. ECT was administered without muscle relaxants, restraints, or prior warnings about the risk. During the violent muscle spasms caused by the treatment, Bolam suffered severe bilateral fractures of his pelvis. The allegation was Bolam sued the hospital management committee, claiming the doctors were negligent for failing to warn him of the risk and for not using relaxants or restraints. So those days, there is no standard protocol like that, but they do their best to what they can do to the patient. And then the committee formed, and the 3 people voted in favor and to decide. And ultimately, they formed the definition called Bolam test, the standard of medical care given by the medical professional with that of a similarly qualified and experienced medical professional in similar circumstances. This is the definition still used and followed, and it tells that if people have similar knowledge, similar skill based, they do the same thing, and with the best interest of the patient, then the negligence doesn't come into play. And this is called the Bolam test, the famous Bolam test. So the medical negligence, there are 4 ingredients. That is duty to exercise care. We know that we have a duty to exercise the care. And there should be breach of such duty to say negligence. And there should be consequent damage because of the breach of the duty. And where the damage foreseeable, suppose an experienced person, a skilled person, no, okay, if there's something that doesn't happen in a treatment or a management, and this can happen, and they can able to foresee the problem. So these 4 things should be present to say is a medical negligence: duty to exercise care, breach of such duty, consequent damage where the damage foreseeable. So what are the laws relating to the medical negligence? Different laws can be applied to medical negligence, like law of tort, that's a civil law, and civil wrongdoing, and law of contract. And when there is a contract is with consideration. So contract without consideration is void. So the contract with consideration is legally valid. And the law of contract and criminal law and Consumer Protection Act. What are the circumstances relevant while determining breach of duty? So we have to see the circumstances involved in the case of the breach of duty, the gravity of the risk involved in the management of a case, whether the patient is suffering from some other associated medical conditions, the common practice of the profession with respect to the management of the case, the available resources and finances. So we have to see everything into consideration, and whether there is a breach of duty from doctor point of view or the team point of view, and all these points are valid to be taken into consideration before conclude that there is a definitely breach of duty. So what are the common negligence problem we face in critical care ward or any other acute care ward or any other inpatient care or any other outpatient care? And the important errors are, first is a diagnostic error, that is misdiagnosis. A doctor incorrectly identifying illness, treating a patient for acid reflux when they are having a heart attack. And delayed diagnosis, an illness such as cancer is identified too late, causing the patient to miss the critical window for effective treatment. So it's very, very important, because medicine is always a teamwork and there are multiple specialists available. And when we know that they need some second opinion or another expert opinion, or should be managed by somebody else, not by a person, then it is very important to follow that protocol. Otherwise, we'll end up in medical negligence issues. The second thing is surgical negligence, never events. That is catastrophic, preventable mistakes like operating on the wrong body part, performing the incorrect procedure, or leaving a foreign object like a sponge inside the patient. Anesthesia errors, administering too much or too little anesthesia, failing to monitor the patient's vitals, or intubating incorrectly is very, very important, because any training should be supervised training and it should be done by a skilled and qualified person. And we have to keep all these things in mind, that to prevent medical negligence, we should foresee what can go wrong if the protocol is not followed. So medication mistakes, wrong dose or drug, prescribing or administering the incorrect medication, the wrong dosage or drug the patient is known to be allergic to. Improper administration, administering the medication via the wrong method, intravenously instead of orally, or failing to track an adverse drug interaction. So it's very important. So all these things can go wrong, because when there is an instruction, who is going to carry out the instructions? So, and overall the part of the team, and are they work as a team? They're able to work as a team. The instruction is followed very judiciously. All those things are very, very important. And treatment and birth injuries. Birth injuries like mistakes made during labor or delivery that harm the mother or baby, such as mishandling fetal distress or delaying a necessary cesarean section. Lack of informed consent. Consent is very, very important. And failing to properly warn a patient of the risk, side effects, or alternative options before proceeding with the treatment or a surgery. So we should discuss adequately with the patient about what we are going to do, what are the issues of doing it, what are the benefit of doing it, where the benefit outweighs the risk, and what are the precautions we have taken, and whether they're happy about going for it, and all those things are very, very important. That we communication, interactions are very important. No excuse for no time to explain, and it's better sometimes the person who do the procedure himself talk to the patient, even though the team is there, or they can sit as a team and he explains important things. The team carry on the remaining paperwork. It's very, very important to prevent any issues in the future. So post-operative hospital negligence. Poor aftercare, releasing a patient too early, or failing to provide proper wound care, leading to severe infections. So it's important. Sometimes patients ask why you are keeping me unnecessarily. And if you have genuine reason to keep the patient to prevent any post-operative complication, we have to explain to the patient that we have a reason to keep you, because some people, patient may think that we're keeping unnecessarily for different reasons. It's very important. Communication prevents a lot of things in life. Failure to monitor. Nurses or staff failing to observe a patient's vital signs, resulting in undetected complications. Very important, like pulse rate, blood pressure, temperature, in the ancient old medical the care. Even though we have a lot of technology and machines available, still that we use the equipment. Sometimes we need a physical examination or physical monitoring also in addition to make sure that everything is going on well. So medical negligence is divided into civil negligence, suing for financial compensation, and criminal negligence, prosecuting a medical professional for gross recklessness. While civil cases only require a preponderance of evidence of a care standard breach, criminal cases demand proof beyond a reasonable doubt of willful gross negligence. It's very important to differentiate civil negligence from criminal negligence. Civil negligence revolves around a breach of the standard of care that directly results in harm or financial damages to a patient. The primary goal is restoring the victim to their original position through monetary compensation. Misdiagnosis or delayed diagnosis, surgical errors, medication errors, anesthesia errors, lack of informed consent, the law of tort, the civil negligence, these things also comes into civil negligence, depending upon the error happened. And sometimes if it's a gross negligence, some of these things can go to the criminal negligence. Criminal medical negligence involves a much higher threshold. It requires proof of gross negligence or recklessness, meaning the medical professional showed a total careless disregard for the life and safety of the patient. A simple error of judgment or a medical accident does not constitute criminal negligence. Criminal cases are typically pursued by the state or public prosecutor, and penalties include imprisonment or suspension of the medical license. So gross incompetence, performing highly risky procedure without possessing the necessary qualifications, training or expertise, resulting in severe injury or death. We should know when to say I can do, when to say when I cannot do. Because nobody is expected to possess all the skills in the current world and the way the medicine has developed and the technology has developed. And we should know that what we know, what we don't know, what we are trying to do, what we are not trying to do. It's very important. That will prevent getting into issues like this. Impaired practice, like treating patients while heavily under the influence of alcohol or illicit drugs, leading to fatal medical errors. Criminal abandonment, willfully walking away or abandoning a patient in a critical condition or discharging them prematurely while they are still in need of emergency care. Gross procedural disregard, completely failing to follow elementary life-saving protocols. So these are all very standard methods, and we know as trained people that our mind talks to us, and most of us don't get into issues because we know what we are doing. It's very important to follow the same standard protocol to keep us away from problems. So this is an interesting case of Jacob Matthew versus State of Punjab in 2005. It's a landmark Supreme Court of India judgment that serves as a definitive legal framework of medical negligence and criminal liability of doctors. It is decided on August 5, 2005 by a 3-judge bench. The court established that medical professionals cannot be prosecuted criminally under Section 304A of the Indian Penal Code for causing death by negligence unless gross negligence is explicitly established. So in this case is hospital admission in February 1995. A patient named Jivan Lal Sharma was admitted to a private ward at hospital in Ludhiana. The incident on February 22nd, the patient experienced severe breathing difficulties. The nurse called for doctors, but they arrived late. The empty cylinder, upon arrival, the medical staff connected an oxygen cylinder to the patient, but the cylinder was found to be completely empty. By the time another functioning cylinder was arranged, the patient passed away. The complaint was the patient's son filed a first information report under Section 304A, causing death by negligence, and Section 34 of the IPC against 2 duty doctors, including Dr. Jacob Matthew. The lower court's appeal was Dr. Jacob Matthew moved to the Punjab and Haryana High Court to quash the FIR, but his petition was dismissed. He then appealed to the Supreme Court of India. The Supreme Court quashed the criminal proceedings against Dr. Jacob Matthew. It observed that the doctor was not personally responsible for maintaining the oxygen supply, meaning the issue fell under administrative or civil liability rather than criminal rashness by the individual physician. Now, there is something called res ipsa loquitur. This is an important legal terminology. The thing speaks for itself. Whenever anything happens, the circumstances, the evidences surrounding the circumstance, the incidents speaks by itself. It's called res ipsa loquitur. It's a rule of evidence mostly restricted to civil tort cases. The Supreme Court ruled it cannot be automatically applied in criminal trials to presume a doctor's guilt. You have to see very thoroughly in criminal negligence cases. So what are the precautions to be taken? Defensive medicine, delivering the standard health care. It's better to deliver the standard health care, and we know that what is the standard health care for a particular situation. Record the consent, always get the consent. Avoid engaging in telemedicine if needed. Ultimately, seeing the patient is important. Without seeing patient, taking decision through phone or telemedicine in difficult situation like pandemic and all those things different. But routine situation that we should be very, very careful using this technology for taking important decisions. Not to abandon the patient is very important. Clarify to the patient when a doctor, the doctor's legal duty concludes. Lack of experience is not recognized as a valid defense. We can't go and say, something happened. I'm sorry, I don't have an experience on this. And that cannot be told because that we know that when we don't have experience, we have to ask for help. To write the prescriptions legibly, documentation. Only way to protect us in problems. Always write a legible prescription and document it, and keep a copy of it is very important. To put on all the advice on the paper. Whatever we talk is better to put it on the paper. We can't say that I told orally and the person can say that he not told me. Then very difficult to prove that we are innocent. And we're better to put down all the advice on the paper. Ensure that the consent is valid and informed one. Defense available to the doctors. No existing patient-doctor relationship. The contract come into play only if the patient-doctor come into the consultation happened, we talk, we documented, then the contract is developed. When there is no contract, when there is no existing patient-doctor relationship, then it may be a defense. All care given ground of negligence upon failure cannot be a reason. So, so once we given all the standardized care, whatever best we can do to the patient and with best of interest, and then just because something untoward things happen, and it doesn't make us liable, especially when everything is followed in a standardized manner. So medical consent is a voluntary informed agreement given by a competent patient to accept or refuse a medical treatment. It upholds patient autonomy and is categorized by how the permission is expressed and the depth of information provided. The implied consent is assumed through a patient's actions, body language, or conduct rather than explicitly stated. Examples like holding out your arm for a blood pressure cuff or sitting in a dentist chair for a checkup. See, kind of implied consent. The express consent is given explicitly either verbally or in writing. Verbal or oral consent is given out loud, often used for minor low risk procedures like getting an X-ray or a standard flu shot. Written consent is signed documentation required for invasive, surgical, or high-risk treatment and kind of things. So you need a written consent. The informed consent is gold standard of medical care. It means the patient has been given a thorough, easy to understand explanation of their condition, the proposed treatment, potential risk, expected outcomes, and alternative options before agreeing. There is something called blanket consent. When a patient signs a board form authorizing a facility to do whatever is necessary, this is generally invalid legally, except in a rare emergencies where specific consent cannot be obtained. So blanket consent is not legally valid unless in a very, very special situations. The role of documentation and consent of healthcare issues. Consent is free, it should be free consent and should be informed and by a person of capacity. And doctor decision, patient had little role in influencing the reason. Once we know that what is the best for the patient, we explain to the patient, we tell what is the pros and cons, and the doctor has to tell. But we can't give off treatment or some in between and tell that I'm sorry, we decided to do this and that's why the poor outcome and all those things. It is better to do the proper standardized care and explain to the patient everything, and that will protect us actually. Sanctity of life versus bodily autonomy. What is bodily autonomy? Is right to decide about what shall be done with his or her own body. Patient has the right to have bodily autonomy. We have to give respect for it. What are the consequences of interventions without consent? So when there is the intervention, suppose we do intervention without consent in a very special situation, in very, very rare special situations, I will talk about it. But otherwise, that intervention without consent is becoming a liability. And what are the laws coming into place? Criminal law, civil law, and professional regulations. Information needed for the patient to give consent. Details of the diagnosis, prognosis, and the likely prognosis if the condition is left untreated. Uncertainties about the diagnosis, including options for further investigation prior to treatment. The purpose of a proposed investigation or treatment, details of the procedures or therapies involved. Everything needs to be talked in detail. How the patient should prepare for the procedure to explain about common and serious side effects. Whether a proposed treatment is experimental. How the patient condition, any side effects will be monitored. A reminder that a patient can change a decision at any time. Right to seek a second opinion and details of the cost. Everything should be explained to the patient. Circumstances relevant while determining breach of duty. The gravity of the risk involved in the management of a case. These are all taken into consideration when people talk about breach of duty. Where the patient is suffering from some other associated medical conditions. The common practice of the profession with respect to the management of the case. The available resources and finances. The duty of care towards a patient as ceased by the time the earliest injury took place. When the patient has recovered from the illness for which the treatment was carried out, when the patient himself abandons the treatment, when the patient takes treatment from another physician without informing the physician who was originally treating him. So the informed consent and the important things are benefits of treatment, the risk of treatment, alternatives, other treatment options, no treatment, risk of no treatment, and documentation like signature, the doctor, the patient, and the witness. Fundamental ethical and guiding principles. Now, what are the fundamental ethical and guiding principles? Are the patient autonomy, which I was telling initially, self-determination, non-maleficence, the duty to do no harm, beneficence, contribute to the patient welfare, justice, equal distribution of benefits and burden, fidelity, the truthfulness and medical confidentiality, and veracity, honesty. So these are all the fundamental ethics issues of any guiding principles. The 4 C's of safe practice is caring, communication, competence, and charting. We have to care. We know all of us care and we communicate. And competency, as I told initially, that without competency, touching a special situation which needs competence is unfair, and that comes under negligence. And charting, documentation, we have to document everything. So caring, communication, competence, charting is very, very important, and to protect us if we're getting into any issues. And for the benefit and safety of the patient as well. So duties, what are the duties of a medical professional? Duties to the patient. We have duties to the patient, we have duties to the public, we have duty towards law enforcers, police, courts, etc. Duty not to violate the professional ethics, and duty to each other. These are all important duty, and which is mentioned in the legality to be followed by doctors. Implied contract is not established. For example, if the patient in particular situation, then the consent comes into issue, like first aid in emergency. When there is an emergency, nobody to accompany the patient, and we have to act immediately. And that is a special situation. First aid in an emergency, pre-employment medical examination. That is a routine thing which has to be done, and examination for LIC and examination at the request of the court. These are important. There are different situations where the routine the recommendations is not thing. We have to follow what to be followed in the particular situation. Documentation, delivering the basic standard of care, which I was telling about the Bolam test, will prevent majority of legal issues. Always keep in mind these 2 important points. If we keep, is more than enough. One is a documentation, and delivering the basic standard of care, what is expected from us, and what we call as Bolam test, will prevent majority of legal issues. So most cited landmark precedent in India regarding consent violation is a Supreme Court judgment in the case of Samira Kohli and Dr. Prabha Matchanda. The incident, the patient went in for a diagnostic and operative laparoscopy. She had signed a consent form for allowing the procedure with a handwritten endorsement that a laparotomy may be needed. However, while she was under anesthesia, the doctor performed a total hysterectomy as well as the removal of her ovaries and fallopian tubes. The doctor had taken proxy consent from the patient's mother, who was waiting at the hospital, instead of waiting for the patient to wake up. The Supreme Court ruled in favor of the patient. The court had held that consent given for one procedure, laparoscopy, does not automatically act as a consent for a dramatically different procedure. The court also ruled that proxy consent from a relative is invalid for a competent adult unless it is a genuine life-threatening emergency. So the total absence of operating without taking any consent at all, exceeded consent, performing a procedure or removing organs beyond what the patient explicitly signed a form for, like this case, Samira Kohli case, and lack of informed consent, obtaining a signature but failing to disclose the material risk, alternatives, and consequences of the procedure. These are the important things we have to make sure it is ruled out, like total absence of consent, exceeded consent, lack of informed consent. That should be informed consent, that should not be blanket consent, and everything should be explained to the patient. In India, the important thing is a will for not to resuscitate is known as the Advanced Medical Directive. I think the awareness is increasing now in India, what we call as living will. It allows adults with the decision-making capacity to dictate their refusal of life, sustaining treatments including cardiopulmonary resuscitation like CPR in terminal illness scenarios. The living will document, you can formally draw up an advanced medical directive indicating that you do not wish to be resuscitated. Do not attempt resuscitation. It typically requires a document to be signed in front of 2 witnesses and countersigned by a judicial magistrate of first class. When will the living will come into effect? Will come into effect only when the person making the living will is unable to make or communicate a decision for themselves. At this time, the healthcare provider will refer to the wishes, preferences, and the refusals stated in the document and will consult the person nominated by the person or their family before carrying out the wishes. The healthcare provider will be guided by the person's best interest, and if the healthcare provider finds the provisions of living will or the opinion of the nominated person or a family is not consistent with the healthcare situation, the healthcare provider has the right to disregard the living will. So especially that if you treat and the patient has a chance of coming out, and all those things are very important actually. So because it was given only in a special situation, but nothing is going to work. The overarching purpose of the living will is to provide a human, comfortable, and dignified end of life and avoid potentially inappropriate treatment against the patient wishes. In India, active euthanasia remains strictly illegal. However, the Supreme Court of India recognized passive euthanasia, which encompasses the withholding and withdrawing of life-sustaining treatment as legally permissible right for terminally ill patients or those in irreversible vegetative state. Active euthanasia is not, India is illegal. Passive euthanasia also, there are only 1 or 2 cases is in special situations, and it is also having a procedure to do it. So the medical boards, for patients lacking a valid advance directive or those unable to make decisions, removing life support requires the formation of a primary medical board and secondary medical board. These boards comprise medical experts who must anonymously determine that patient's condition is irreversible or has no realistic chance of recovery. The judicial oversight. The hospital must communicate the decision to the judicial magistrate of the first class. In specific cases with extended vegetative states, the Supreme Court has set precedents for judicial approval of withdrawal, provided comprehensive palliative care is administered. This living will or advanced medical directive, you can get the form from the Palliative Care Association, and the form is also available in the website actually. And there is a case called Aruna Shanbo case, a landmark in Indian legal history that established the legal framework for passive euthanasia. While the Supreme Court ultimately rejected the mercy killing plea for Shanbo, and its 2011 judgment legally recognized passive euthanasia under strict judicial supervision. The background is Aruna Shanbog was a junior nurse at King Edward Memorial Hospital in Mumbai, was brutally assaulted and left in a permanent vegetative state in 1973. All the nurses in the hospital were taking care of Aruna Shanbog for quite a long time. And there was a petition in 2011. The journalist and activist Pinky Virani filed a petition in the Supreme Court of India seeking euthanasia on Shanbog's behalf, arguing that her condition was irreversible and she was living in immense suffering. The verdict was on March 7, 2011, the Supreme Court denied the plea to end Shanbog's life. The court reasoned that she was being cared for diligently by the KM hospital staff and that hospital staff themselves opposed the euthanasia request. The staffs worked with her and they are still working with her at the time. And the junior nurses joined later and everybody is attached to her. And they have been giving a good care for so many years to Shanbog. She was one of the staff worked in the hospital. And this thing happened in the hospital premise itself. And the guidelines said it allowed passive euthanasia, but only under strict supervision by the High Court and a panel of medical experts. As I was telling initially that you need it involved a medical, first-class medical magistrate, judicial magistrate, and there are two medical boards, primary and secondary medical board, and the situation to be gone through. So many guidelines are there to prevent, it should not be applied just like that. And Shanbog's death, Aruna Shanbog never underwent euthanasia, and she passed away naturally from pneumonia in May 2015 after spending 42 years in a vegetative state. And so that is the first case. It is discussed in all the legal books and all the legal discussions. There are extensive report on this case, and this is the first case people gone through about this passive euthanasia and the procedures and all the court recommendations and all those things. The legal evaluation, the framework established in Shanbog case laid the groundwork for further rulings. In subsequent years, the Supreme Court expanded the right to a dignified death to include living wills, advance directives for terminally ill patients, allowing individuals to refuse life support. So they saw that I think this living will awareness, I don't know how much, and I think there are awareness different level, and the forms, as I was telling initially, is available on the website as well as in the Palliative Care Association site in the website also. It is of India, Palliative Care Association of India. So there is another case called Arish Rana euthanasia case, the Arish Rana versus Union of India. This is a 2026 case. It's a landmark legal milestone in India, marking the first ever real-world implementation of passive euthanasia for an individual patient. On March 11, 2026, the Supreme Court of India permitted the withdrawal of life-sustaining treatment for 32-year-old Arish Rana, who had been in a permanent vegetative state for 13 years. Following the court approved the medical protocol, he was shifted to the palliative care unit, New Delhi, where he passed away peacefully on March 24, 2026. So that all this protocol has to be followed. So there is a difference between not to resuscitate, do not resuscitate, and there is and living will and passive euthanasia, and everything need it's a teamwork, and there should be a board and committee and all those things to prevent a decision made on a few people level and getting into issues or problems. So it is it's a quite vast topic. I don't want to bore you with too many information. I not covered the Tissue Transplant Act and the organ donation and brain death, which is a very big topic by itself. So there will be many questions, and some of the questions, the answer itself will take many minutes, because in law you have to give a long answer, not a short answer, because you need to quote a lot of things. So there are untouched areas. Brain death and organ donation, tissue transplant are separate big topics. We'll discuss in some other lectures. Any questions, kindly email to me to save time, because it's Sunday. I don't want to prolong the meeting by going on talking. So note down my email address, and if you have any specific questions, kindly email to me. I will answer to you back, so that we can go back to the next talk and finish in time rather than prolonging the webinar for a long time. Thank you very much for listening to me.
Yes, thank you. Thank you very much. Yes, please put this slide up. So, Fazani ji, can you please put your first slide up? The introduction slide that just came up. Yeah.
Oh, you want? Okay, I'll do that.
It was my duty to present you to the audience, but I know you
Okay.
spoke very well. But you are a true polymath.
No,
Yeah,
I think most
put up the-
of our colleagues know about it, Dr. Partha.
No, the
I think-
juniors don't. I think
you
you're
want
an
to-
inspiration. I request you to put the first slide up, and
Okay,
I'll make
okay.
some comments.
Okay,
In the
okay. I'll do
meantime,
that.
yeah. And Asmita ji, there was a question from Dr. Rahman. Please promote him to a panelist and then unmute him. But in the meantime, let me thank Professor Pazani, who is putting his first slide up. So you will see what a polymath is in modern day neurology, and it's possible. Apart from all the highly skilled neurologists that we have among 3,000 members, here is one gentleman who has done yoga, accredited medical legal practice. I'll come back to that. He's got music degrees and he's got Bharatnatyam degree, which we saw. So, I mean, we're really truly privileged to have somebody with this sort of CV. I'm really feeling very, very honored. At the same time, very, and I shan't say jealous, but very wishful that I could have done all this. But maybe the next generation can live up to the great ongoing academic exercises that Professor Pazani has done. Now, we'll give way to Dr. Rahman in a minute. Just let me sort of say that this was actually a talk that was a whirlwind. He tried to present, Dr. Pazani, the entire gamut of the entire medical legal aspects of critical care neurology in 40 minutes, well, actually 35 minutes. So, critical care neurology being a very complex area where there's multiple members, different quotients of risk benefit ratio, and a lot of opinions and judgments, and final outcome is often multifactorial. So it is here that his emphasis on documentation, transparency, very important, and duty of candor or true honesty, which is very difficult to keep because that often solves many problems before they arise. Good communication, orally, verbally, and also documenting. If it hasn't been documented, it hasn't been done or said, is the legal dictum. So I think this particular talk told us in a very brief about the four C's, about the duties. But then there was the constant discussion as well. There were innumerable case references and a lot, three or four landmark cases from India, and there's plenty more. And he also touched upon the will and the living will, the advanced medical directives, the euthanasia. So it's a huge subject. We'll have to actually, the postgraduate diploma in medical license and ethics course, which I have taken, and Professor Pazani has passed it. I'm not sure if anybody in IN has the same qualification, but I stand corrected if somebody else has it. It's a 42-week course. It's a national university in Bangalore who run it, and I think that would be my recommendation for aspirant young neurologists to take up this medical legal work to serve the country, to serve the patients, to help their colleagues who are also very scared so that they can approach evidence-based medicine with due rigor, knowing when to ask, what to document. So it's a disciplined activity. It's a highly intellectual activity. It's very interesting. In the last Kochi conference, we had a small medical legal book given out by a dentist who has accumulated a lot of cases. I'd recommend that because the courts are relying on us, you, to tell them what the technical parts are, what the balance of judgment is. This we do through 40 years, 50 years in our cases of clinical practice, but they haven't any idea of that. So when a claim comes to them, a litigation comes to them, they will turn to people like Professor Pazani for advice or how to dissect the case. The lawyers don't know medicine. So here we are having a dire need for truly skilled, honest, transparent, high functioning, dedicated professionals like neurologists to serve the country better. I think that would be very good. Yes, it's very much streamlined into ethical medicine, but at times ethics becomes relevant. Interpretation aspects of ethics, the Bharatiya Nyaya Samhita has come in. So we live in changing times, and we're working towards Viksit Bharat. So we have to learn the medical legal aspects to be safe for the patients, safe for the doctors. So it's protection of doctors, protection of patients, and protection of the system, and having confidence and the assurance of the public in people's competency. I will now give way to Dr. Muhammad Atika Rahman to ask his question. He put a very complex question, so I thought it's better if he has a direct dialogue with you, Professor Pazani. Dr. Mohammed,
Thank you.
unmute yourself, sir,
Thank you, sir, for
and
giving
turn the video
opportunity.
on. Yes, sir,
Yeah,
of course.
thank you, sir, for giving
Always a pleasure.
opportunity. Sir,
Turn your video on.
sir, uh, sir, my video is not working.
Not to worry. Ask the question.
This is regarding the promotion of services by the hospital or the professionals in the electronic and the print media. What are the ethical boundaries? Because a lot of people are promoting the our services as well as the doctors in the electronic as well as in the print media. What are the ethical boundaries in promotional activities?
So the important thing is the Data Protection Act actually, and it is our duty to protect ourselves to make sure that the patient photographs and identity and their illness details are not displayed publicly. It has issues and serious issues as per the recommendation, and it's better to avoid taking a photograph with the patient, putting in the social media, or putting their medical details into the social media and revealing their identity along with that. So the law is there in all the websites available. The latest Data Protection Act, NMC site, you can see in the website. If you go and put all the rules and regulations are well formed. Sometimes I think it is ignorance, and but ignorance shall law no excuse data. The first thing, the motto I got when I joined law degree is they given me ID card with a word called ignorance shall law no excuse data. They cannot go and tell that I'm sorry, I don't know. Everybody is supposed to know the law of the land. So it's better we have to protect ourselves. What others do, we don't know. But I think we should know and we should protect ourselves. Even if we are an institution, that we are alone when problem comes into play.
Thank you, Dr. Pazani. That was good. Yes, it's a very relevant question. We have a Dr. V.S. Manek putting his name on the chat box. Did Dr. Manek want to ask a question? In which case, we can unmute Dr. Manek and we can let him speak. In the meantime, keep putting questions in the chat box. The plan is that we will soon give way to Pushkar Pazani for his case, but in the meantime, we are happy to take one or two more questions.
They can
But
send
we'll come
send
back to
me
questions at the
WhatsApp
end.
also, or they
Absolutely.
can email to me.
Exactly. Yeah,
No
yeah,
problem.
yeah. I'll put we'll put your email up on the WhatsApp group so that everybody gets a chance to ask you a question later. So, Dr. Manik, do you have a question, sir? If because I see your name on the chat box. If not, I think with Sri's permission, we can move on to Pushkar's presentation. But we'll take
No,
again questions
no,
from
sir.
Dr. Pazani
No
at the
question.
end. No more questions. Oh, Dr. Virendra Manik. Yeah. Okay. Okay. No questions, sir. Okay, sir. Okay. So we'll now give way. I'll let Dr. Srivartan present
Yes, sir.
Pushkar,
Yes, sir.
who
We'll
is,
proceed, sir. Yeah.
yeah, we'll proceed. But you want to present, you want
Yes,
to
sir.
introduce Pushkar to the
Yes, sir. I'll
group?
do that.
Please do.
So, on behalf of Dr. Parthare and myself, I again thank Dr. Palani for the excellent talk he has had. And I believe it's an important eye opener for us. And as practicing physicians and neurologists, we need to understand good clinical practice, ethical treatment, and legal treatment are not always the same. And we need to tread the path very carefully. And he has been kind enough to share his contact details. Should any of us have any doubts, we can always take the liberty to bother Dr. Palani and get ourselves clarified with these doubts. And wasting no further time, I introduce Dr. Pushka Palani. He's a colleague of mine, was completed his DM Neurology in JIPMER, and currently is pursuing his fellowship in Intervention Neurology in SIMS, Chennai. So please, Dr. Pushkar. And most of our people here might be aware that Pushkar is someone who tops or wins most of the quizzes conducted at the neurology level. And there are scenarios where we have specifically made sure Pushkar is not part of the quiz because they are not able to set the questions to his candidates. So please, Pushkar, the floor is yours, and we are looking forward to your case.
Thank you for the very kind introduction, sir. So I'll just share my
Welcome.
presentation. Thank you, sir. I hope my inaugural slide is visible.
Not
It is, I'll
yet.
step.
Not yet. Now it's come through.
Okay,
Yes.
thank you. So, good evening, everyone. First, I would like to thank the IA and Neurocritical Care subsection for allowing me to present. And I'll also like to thank my teacher and my mentor, Dr. Ritesh sir, as well as Dr. Selvin sir from the Division of Interventional Neurology in SIMS for allowing me to present our unit's case. So, I'm Dr. Pushkar. I'm a neurologist by training, and I'm a first-year National Board Fellow in Neurovascular Intervention in the Division of Interventional Neurology at SIMS Vadapal. So, first regarding her case. So she was a 35-year-old female patient. She was pregnant, her obstetric score being G3P1L1A1. She was 18 weeks at her period of gestation. And other than the fact that she had gestational diabetes mellitus and she was on low dose aspirin started by her obstetrician, she had no other prior medical issues. So she had presented with a 3 months history of daily persistent headache. And this was side locked to the right side. It was throbbing in nature. But however, there were no migrainous features. There was no visual aura, no neurological aura, no nausea, no vomiting or photophobia. There were no visual symptoms, no facial deviation, slurring of speech, or any weakness or any sensory deficits. And this headache has been getting worse with regards to the severity for the past 1 month. So on examination, her vitals were stable. There was no papilledema. Her cranial nerve exam, her motor exam, her cerebellar exam was normal, and she had no focal neurological deficits. So to summarize, a 35-year-old antenatal mother with 18 weeks of period of gestation, presenting with a 3 months history of daily persistent headache, which was worsening in severity for the past 1 month, with a normal cranial nerve, motor, sensory, and cerebellar examination, with a background history of background clinical condition of gestational diabetes mellitus. So at this juncture, whether we work up this patient as a primary headache or a secondary headache, definitely she needs to be worked up as a secondary headache because it's a new onset headache. She's never had such a headache of such severity at any point of her time. And number two, considering the fact that she's pregnant, that's another reason that we should consider this as a secondary headache and not a primary headache. So considering the fact that she's pregnant, definitely doing a CT scan is out of question. So we went ahead and did an MRI. So we can see in the MRI, first in the T2 sequence, we can see that there is uh, both hyperintense and hypointense, a very heterogeneous lesion involving the right parietal region with surrounding significant vasogenic edema and with a definite mass effect in the form of midline shift. And if you look at the SWI sequence, you can see that there is significant blooming in that lesion. So what we are seeing over here is an intracranial space occupying lesion, which is intraaxial in the right parietal region, which is hemorrhagic in nature, and there is significant vasogenic edema with a midline shift. So this was her TOF sequence, her MR angio. So usually bleeds can sometimes cause this artifact over here, but otherwise it is quite unremarkable. Unfortunately, I could not get her MR venogram images, but that was also normal. So these are the differentials that we're considering at this juncture. So the patient could be having a cavernoma with a bleed. She could be having a cortical venous thrombosis with a hemorrhagic venous infarct. She could be having a tumoral bleed, either a primary brain tumor, which is undergoing a hemorrhagic change, or a metastatic brain deposit, which is undergoing a hemorrhagic change, that is a tumoral bleed, or it could be an AV malformation with the bleed. So these are the differentials that we were thinking about. And other than the differentials, we had a lot of clinical challenges in this particular case. So by virtue of the fact that the patient is pregnant, she has significant mass effect and midline shift. So neurosurgical follow-up to look for the worsening midline shift could not be possible because serial CTs cannot be done because of the radiation exposure. The only thing that we can do safely is an MRI. The number two thing that we are considering is we were considering a vascular malformation. And to definitely confirm this, we need to do a catheter angiography or a DSA. But however, this also does have the risk of radiation exposure. However, it's significantly less compared to that of a CT scan if done with appropriate safety measures. And the third clinical challenge that we had is, do we continue the pregnancy or not? So for this particular patient, this pregnancy was very precious. It was after around 8 years after her first child, and she was very, very keen on continuing the pregnancy, even though the husband was actually not that keen. So it is very important that we respect the mother's wishes in this case. So these are the treatment options that the neurology team, the neurointervention team, the neurosurgical team, as well as the patient's family, we all had sat down and discussed this. So what do we do next? So do we wait and watch She had no neurological deficit at any point of time. So do we do an internal MRI? Do we continue the pregnancy? Do we wait for neurological deficits? Do we directly go ahead with a neurosurgical option, that is, we do a decompression and possibly see directly what the lesion is, because it's quite superficially placed near the parietal cortex. And next, do we terminate the pregnancy and evaluate the patient as we would as a normal non-pregnant female patient? And the fourth option was doing a catheter angiography, because we did have a strong suspicion of a vascular malformation. So this could be done with reasonable safety, with adequate safety measures to limit the radiation exposure. So the final decision that was made in concurrence with the neurointervention team, the neurosurgical team, and the patient's family is to go ahead with a diagnostic angiography, a catheter angiography with appropriate radiation safety. So we had performed the DSA with a right via the transfemoral route. We had taken a common femoral axis with a 5 French short sheath, and we used a Wert 5 French diagnostic catheter. And with 2000 units of unfractionated heparin and lead shielding over the abdomen, we had proceeded with the DSA. So this is the DSA images this is the angiogram images of the right ICA angiogram. So this is the right ICA AP projection, and this is the lateral projection. And to quite a surprise, we were expecting either a AV malformation or some other vascular malformation, but what we did find is there was a dissecting fusiform aneurysm involving the distal M3 segment of the middle cerebral artery. So you can see in the AP view and similarly in the lateral view. So this is a very morphologically very dangerous aneurysm. It could rupture at any point of time. I think luckily it was sealed by the surrounding hematoma, and the patient did not have a catastrophic neurovascular event. So this is just the videographs of the right IC injection, AP view. So you can see that there is a dissecting fusiform aneurysm in the right M3 segment of the MCA. You can see it's a very dangerous aneurysm, so it could rupture at any point of time. And this definitely warrants treatment. And whether we would go ahead with an endovascular approach or a neurosurgical approach, definitely this particular aneurysm can be treated safely, and it is also technically possible via endovascular route. So the final plan was to go ahead with the endovascular right M3 segment of MCA, parent vessel sacrifice, using glue embolization. So we had done this procedure under general anesthesia. So again, with appropriate lead shielding over the abdomen, with the right common femoral artery axis, this time with an 8 French short sheath, and with an infinity guiding catheter and a vector distal axis catheter. We had taken a marathon micro catheter over the synchro micro wire and then embolized the feeding artery to the dissecting aneurysm with a 50% concentration of glue. So these are the images. So this is a selective microcatheter angiogram. So you can see this is our microcatheter here. So this is the microcatheter, and we are giving contrast via this microcatheter. You can see that this is the normal continuation of one of the M3 branches, and here we can see this is the M3 segment that is feeding the aneurysm. So this is the aneurysm over here. So this is the aneurysm, and we had initially crossed this particular segment with the microwire, and then you can see that we have cannulated this feeder with the microcatheter. So even though it's only 2 slides, I think our consultants, our team, it took almost 3 hours and lot of radiation to cannulate this vessel. It was very technically difficult to take that particular U bend, but finally it was possible, luckily for the patient and for our team. And we were able to do a glue embolization with 50% neuroacrylate, that is glue. So just a before and after comparison, you can see before this is the aneurysm, and after glue embolization, you can see that the aneurysm has completely disappeared. So it is quite a good radiological result. And post-procedure, the patient had no pre-procedural complications. Her post-procedure neurology was exactly the same as her pre-procedure. And the final, of course, we had discussed that there was radiation exposure during the procedure, both for the angiogram as well as for the embolization. We also did discuss with the obstetrician, but considering the fact that the patient had crossed the first trimester and they were very keen on continuing the pregnancy, they were also offered the option of termination by the obstetrician, but they were very keen on continuing. Patient is still under our follow-up, and this is the scan which is taken 2 months after. This is the index scan which we saw earlier, and you can see the scan which is taken after 2 months. You can see that the mass effect has reduced, almost disappeared. The midline shift is gone, and the size of the lesion also has come down, and there is no edema. Uh, that's about for this case. This is our team. And if there are any questions, I'll try to answer it.
Yeah, thank you, Pushkar. Thank you very much for agreeing to my request to present the father-daughter sort of session today. I'm very
Yes,
grateful
sir.
for that. I think
Yes, sir.
there's a question for you that just come up
Yes, sir.
from our good friend Dr. Mohammed Atikur Rahman. So he has
Okay,
asked a
sir.
question. Do you want to unmute Dr. Rahman and ask the question directly to Pushkar,
Yes, sir.
please?
So I think sir has asked why surgery was not preferred considering the more than 5 hours radiation. So we did, sir, thank you for the question, sir. So we did actually discuss with the neurosurgical team after the angiogram whether a surgical option would be feasible. So surgically, one option would be that they can trap the aneurysm, but they were not very keen because they felt that it was quite a high risk surgery from their side. And this was definitely something which could be treated uh, with an endovascular approach. We could get a complete cure with endovascular approach without causing any major deficits. And the opinion from the neurosurgical team is that trapping the aneurysm by an open surgery might be technically challenging and with a high risk of periprocedural complications. So we did discuss this option with the team, sir, and how
How
the
much
final decision,
radiation? How much radiation was calculated?
sir, around 400 DAP, sir.
Okay.
Yes.
So, yeah, Pushkar, I mean, can you show us some literature or tell us what the literature is in regards to
Yes, sir.
radiation in the second trimester and
Yes, sir.
the follow-up of those patients in
Yes, sir.
regard to any congenital birth abnormalities? And
Yes, sir.
how is the baby born now? What's the
No, sir, no,
situation?
sir. She's still under our follow-up. I believe she was 20 weeks. I think delivery date is
Okay.
around, I believe, in 2 more months, sir. So
Okay. Has a
as of
fetal
now, all the
MRI been
scans,
done? Has a fetal
sir,
MRI been done?
fetal MRI has not been done, sir, but her obstetric
Fetal ultrasound?
scans are are normal, sir. Till now, it is normal. Sir, regarding literature for
Yes,
exposure
please.
during pregnancy, so during the first trimester, of course, there is a risk of major congenital anomalies. But
Yeah.
regarding literature in the second trimester and above, there is data to suggest that there is a risk of IUGR, but major fetal anomalies are definitely considerably less compared to the first trimester, sir. So,
And
but
you,
however, there was a lot of evidence for IUGR, but for major anomalies, there wasn't much of evidence.
maybe you could share some papers on the
Oh,
webinar group,
definitely, sir.
WhatsApp group later. And the
Oh,
question
definitely,
was
sir.
that you had shielded the abdomen,
Yes,
hadn't
sir.
you? So
Yes,
there
sir.
was no direct radiation to the baby, to the fetus.
Yes,
So
sir. It
tell
is
me now
limited.
then, how, yeah, yeah, when, is it, when you say limited, so how many of those 400 depths, I didn't quite know, I don't know these numbers.
Okay,
So
sir.
when you're shielding the fetus
Yes, sir.
completely with the lead shield and you're
Yes, sir.
working on the head, I mean,
Yes, sir.
why is there a problem? Please explain to me.
Sir, it's not a problem, sir. I mean, we also do usually do wear the lead apron, so we do minimize
Yeah,
the radiation that,
yeah, yeah.
but of course, there might be some amount of radiation that which will be,
Where,
but it definitely lead
where is the
shielding will,
literature? Where is the evidence?
I'll go through it,
Okay,
sir.
anyway, you share with us later.
Yes, sir.
No, it's critical questions because
Yes, sir.
Dr. Rahman asked the question because
Yes,
you're
sir.
giving this radiation, but you're
Yes, sir.
shielding the baby. So how
Yes,
is
sir.
the baby getting damaged, even if it was a situation in the first trimester?
Yes,
Because
sir.
these are the critical questions the judge will ask you.
Of course, sir.
Well,
Yes.
somebody when we get into this thing. And so, where was the medic? Since it's actually medical legal sort of, inspired by your father. So
Yes.
this section. So tell us the medical legal problems you had during discussions.
Sir,
You
number
finished
one
your presentation,
was,
haven't you? Yeah, you
yes, sir.
you
Yes,
finished
sir.
it. Yeah. So now is
Yes,
the
sir.
time for free discussions on this case
Yes, sir.
to
Yes, sir.
discuss the medical legal
Yes, sir. Sir,
torturous
number one
discussions you may
is,
have had.
yes, sir.
Yes, go on.
So number one was regarding the consent. So usually we do have a generic consent for our angiograms and for our procedures. So we had to make a special consent in this particular case where we had included the possible effects of radiation and the possible need for termination of pregnancy. So these were additional points that we had included in the consent forms. And number two, we had also involved the obstetrics team while making the drafting the consent form for this particular case. And we had also made sure that the obstetrician had put notes for this particular patient every day, and I'll also documented the fetal heart rate every day. So
But isn't that quite standard of care?
yes,
What
it
you
is,
just
sir.
said now is
Yes,
pretty
sir.
much what everybody should be doing every day.
Yes, yes, sir.
Medical legal case or complex case or not, documenting fetal heart sound, fetal heart rate, and
Yes,
doing
sir.
conversation with the patient is a standard clinical practice, isn't it? Now,
Yes, sir.
when you said about the question, I'll be a bit provocative here. Why was the question at all raised of terminating the pregnancy? What was the need? Where was the
Sir,
problem?
sir, I didn't get
You
your question,
said
sir.
that, yeah, you said there was at one point a discussion of whether the pregnancy was should be terminated. It's a precious
Yes,
baby
sir.
after
Yes,
eight
sir.
hours, 8 years.
8
The
years, sir.
father was a bit more liberal, but
Yes,
mother,
sir.
being mother, was very keen that she hang on to the child, which was very
Yes, sir.
precious to her. So
Yes,
why
sir.
in this situation the discussion of terminating the pregnancy because there was a
Yes.
lesion in the brain
Yes.
entertained? Just want
Yes,
to
sir.
tease out the logic.
Sir, number one, the obstetrics team was very keen on termination, sir, because the
Why?
workup of the patient was getting affected because the fact that she was pregnant, we couldn't, and she had significant midline shift, around 6 millimeters. So, getting a follow-up CT or taking up for an open surgical procedure, and the obstetrics team was very keen on termination so that she could be worked up for her cerebral issues, her neurological issues, as she would if she was not pregnant. That is the main concern.
You
So,
can't sacrifice a life for unborn life, which is
yes, sir.
viable fetus, if it's
Yes, sir.
crossed 24 or 28 weeks, to
Yes,
allow a
sir.
patient's
She
brain
was
to be
18 weeks,
affected.
sir. Yes, sir. She
18
was
weeks, okay.
18. 18. She
Okay,
was 18 weeks.
yeah, but still, I mean, we have operated on patients with
Yes,
on
sir.
their brain
Yes, sir.
to preserve the fetus because
Yes, sir.
apart from IUGR, from what you're saying,
Yes, sir.
intra-uterine group retardation, there is no. The reason I'm bringing up these issues because the common man on
Yes, sir.
ChatGPT and Perplexity will be asking these questions to
Yes,
all
sir.
of us
Yes,
before
sir.
we know. So we better get prepared for this because
Yes, sir.
we have a very educated Indian population, and so it should be. So we should be able to answer the questions truthfully and correctly. Just mentioning about termination of pregnancy is so hurtful emotionally.
Yes, sir.
That's why I asked you as to why even that question was asked because of lack of monitoring.
Yes,
And
sir.
if it comes to worst case scenario, the mother's life's got to be saved, isn't it?
Yes,
And
sir.
if as a consequence of that, there is accidental miscarriage that takes place,
Yes, sir.
then that's in the hands of God, or that's how the balance of truth will eventually lie. Right. So I think I've just been provocative to raise some questions. So I let Dr. Sri and other participants put questions in the chat box or raise their hands, and Asmita ji will unmute them and ask questions for both Professor Pazani as well as our good upcoming, very good friend in Pushkar. So please feel free to, we have got time. So we are on time basically. So please ask questions. And I'll ask Dr. Sri also to, inquire of Professor Pazani and Pushkar some queries in the meantime. Everybody is now welcome to ask questions and, carry on a bit more. We have got time.
Thank you, sir. And that was a wonderful case, Dr. Pushkar. The
Yes, sir.
MRI was maybe, I don't think aneurysm would have been the first suspicion for anyone with just that MRI. It looked more like a cavernoma bleed or some kind of a AV malformation.
Yes, sir.
But it was an excellent presentation. I just have two insights to give, might not be applicable to you, but to the other people who are listening. I think it was in 2016 or 17, the ACOG has made a point very clear. The American College of Obstetrics and Gynecology, that beyond the first trimester, CT scan is safe. So we normally assume that pregnant women should not undergo a CT scan, but ACOG has actually made a position paper, and the justification they have given is the exposure the fetus gets while doing a routine CT scan of the brain is actually less than the exposure the fetus gets by just being in an ambient environment. So the radiation risk is quite less. Initially, they had suggested that we need to use a lead shield to cover the abdomen while doing CT brain, but right now, even that has been removed. So what you did was absolutely correct. And there is no reason to deny a CT brain or a CT angiography just because a patient is pregnant. And this is again highlighted at multiple levels in the ECOG position paper. Just because Dr. Palani had given this previous conversation, this is also part of the ethical obligation. We need to be aware of what the position paper is. We cannot blindly say something is not applicable for a certain patient without knowing what the science says. When it comes to DSA, then the conversation is completely different. So it has to be on an individual tailored basis, and I think you have covered every box. So it was a wonderful case. More important than that is the wonderful approach which you have done for the treatment part. And kudos to your team. About the termination, which Dr. Parthare had a discussion, I think we don't have a straightforward answer. The OG team was probably justified in saying that the termination would have been a viable option to hasten the treatment. Since the patient has recovered very well, in hindsight, termination of pregnancy seems to be a big topic. But had things gone south, then the same questions would have come, why we had not offered termination. So you are 100% correct in offering that. We talk in hindsight most of the things, but it's always a very difficult situation when you are in front of the patient to give an answer. So anyway, that was a wonderful case. And if there are
Yeah.
no,
I'm not,
yeah,
let's proceed that discussion a bit further. Thank you for raising the contra view, because we still don't know whether the radiation, despite the papers that our Pushkar quoted, do not are shielded by the lead shield. And now you're saying there's no need for lead shield either.
so that is only for the CT scans and not for the DSA.
Yeah. So basically, we are protecting the baby.
Yes, sir.
And there came a counter argument that we should sacrifice the baby to be able to proceed with the mother's delivery of care. And now we have a situation where the mother is safe,
Mm.
and baby, from the basic scanning, which is ultrasound, seems to be all right. And we don't have an MRI of the baby, and there's a lot of high-end imaging of the brain of the baby within the fetus that can be done, within the womb that can be done, which we don't have access to. So it's still a waiting game to see whether the baby has in any way been compromised. Now, the compromise will be in terms of any genetic defects as a consequence of radiation. But I still don't know as to, unless you radiate the baby directly, which you
Exactly.
haven't, how can you cause a chromosomal or a DNA or any microRNA problem? I don't know. So, but we will await those two papers or three papers that Pushkar promised to send us for our own education. Because, and obstetricians basically are, I think, hostage to some lack of information. So they're basically playing it safe. And I have a life to save out here and a precious baby that both parents want to keep as much as practicable. And the worst case scenario would have been the flip side is that as a consequence of undertaking emergency surgery, the baby may not have survived. But that's nature's way of, taking care of things at times. Now, if we now come up with a baby who is compromised, brain-wise or any organ-wise, in the next, what is 30 weeks now? In 2 weeks' time or
Yes, sir.
whenever, then I will have to you know, revise my position and go back to the drawing board. So, I mean, these conditions, situations are very common in any advanced medical care, as is India and China and everywhere. So, I mean, what panel do you set up and who contributes to the panel and what discussions are had? Are they documented? Is the patient part of that panel? Is the husband part of that panel? Is there a lawyer a part of the panel? Because you see, at the end of the day, I'm only as good as the opinion I give in a structured environment, knowing that one day these things will come back and bite me. So I'm deliberately, putting it some criticality into this rather than a casual on the corridor conversation. Ha, theek hai, terminate kar do. That's not the way medicine is done anywhere, and we shouldn't do it. If it was my baby, I would have actually asked these questions. So anyway, what did you have actually a board meeting? Did obstetricians have actually a board meeting with the, radiation people, the intervention neurology themselves, the parents, the counselor, the GP? Did you have all that setup done, or was it just off the hoof?
We had a formal family meeting, sir.
Yes,
Didn't
yes.
call it a board meeting, but definitely there was a formal family meeting.
Right, right. And there the mother was very keen that she be
Mm.
able to keep the baby as much. Well, I think that's all mothers do,
She
protect
was.
their offsprings. Yeah, yeah. But thank you very much. So yeah, I deliberately waded into a lot of ethical discussions and inter-Trinitian dilemmas and conflicts that we all suffer from and we have to deal with as a daily practice. So yeah, we're just waiting for some more questions. And with Sunday, and I don't want to bore people with more of us, but I thank everybody. Any last comments from Professor Pazani you would like to give, particularly to the coming up generation who haven't been fortunate or as talented as you to pursue so many fields? But where do you think the young critical care neurologist or the young neurologist would go to learn? Is there a course? I know the PGDMLE. There are some books, which is a good book. Maybe you can tell them by email. But how would you think we proceed with the medical legal aspects of critical care neurology and medical legal aspects of neurology for the next generation to put them on the right track and not have an ad hoc learning, but a structured learning program? Over to you, sir. I think you're muted, sir. Unmute yourself, please. Sir, you're muted. Professor Pazani,
I-
yeah, we
uh,
can hear you.
Can you hear me now?
Now,
Okay.
now we
And
can hear
the
you.
important thing is general neurology with special area of interest. That's what I recommend to the coming
Okay.
generation, because that's how the British system and European system, many are general neurologists, special area of interest. American Academy, I am part of it, and they have the general neurology level has gone down to 24%. So they have
Yes.
been trying their best to improve the level of number of general neurologists. I request all the youngsters who are doing extremely well and technologically and professionally to do both general neurology with special area of interest.
No, my question was a bit different. How to bring in the medical legal neurology? This
I
law, the
think
torts, the civil
I
claims,
think it may be
on all this. Yes.
it may be better to have um, a paper or maybe a few questions on medical legal aspects in medicine,
So
because it
into
is
the NMC curriculum.
there are some countries they included jurisprudence as part of the medical paper, one paper on jurisprudence. So it may be better that one or two questions on one particular paper can be on medical legal issues. So the awareness will be
Yes.
better with the important things like what is consent and what is negligence, and some
Yes.
cases, some interesting cases, and those kind of things. No need to be very thorough knowledge. And what are the
Well,
important acts applicable? Important acts applicable
well,
to the medical profession.
we had forensic medicine in
Yes.
our second professionals, along with
Yes.
pathology, pharmacology, and I think community medicine. That was the fourth subject we had.
It
And that had
doesn't
its last few
cover.
chapters. Yeah, but it gives an intro. So I think in DM neurology or DNB
Yes.
neurology, NMC should also incorporate quite a bit of medical legal practice subjects. Why don't you take the initiative, sir, and write as part of the IAN with the president's
Yes.
permission
We
to
can
get
try.
people to
Maybe,
incorporate that?
as he told rightly, that we can, in forensic medicine itself, there may be few
Yes,
questions on medical legal instead of creating a separate subject. And I think people can write to the decision makers that can make people to understand some important concepts for safety of practice, both for patient and doctors.
yeah, in a structured fashion. Yeah. Right. Thank you very much. Is there anything else you would like to share from your vast experience on the medical legal topics in neurology with our juniors? Waiting for you. We'll, of course, invite you to a few more talks in the future, as you said, on organ transplantation, and it'll all be guest lectures. So we'll invite you. You have to come back a few more times to educate us on areas that are not covered very commonly. But a critical care neurology, ITU setting, organ transplantation, brain death, and you touched upon palliative care, which Professor Gulshahani also does, and a lot of people do as well. So these are the borderlands, the boundaries of neurology and other specialties. Anesthetics as well also contribute to this. So there's a lot of few more times to be
Quite
got.
large topic. Brain death and
Yes.
transplant act are quite large topics. And so I
Yeah.
thought I will avoid that and
Exactly.
cover
No,
everything.
no, do the right thing by keeping it simple and
They need a
clear.
separate talk, actually. Brain death and
Absolutely, absolutely, absolutely.
transplant act.
Yeah. Okay, we'll ask Pushkar to tell us what it looks like from your, startup block. You're sort of starting off in this huge field, following your father, sort of immense footsteps. So, what does it look like, the field to you as a youngster? May I ask you?
But I think I'm still a student, so I think I'm still
Yes,
not
we all
out
are.
into the.
We
So
all are students. But
yes,
what
sir.
does it look like? How does the future hold in neurology, medical practice, clinical, critical care neurology? What are your needs is what we want to know so that we can frame the field depending on your needs. We have actually driven our vehicles on that road. You come in different vehicles. So what does the road need to be like for you to drive efficiently for our Bharatiya, people? What are the roadblocks? What are the, bumpy potholes? What have you seen? Just give us two where you think one things better, changed, more people centric, patient centric. I know it's a difficult question, but we like to hear you.
I think easy access to learning materials, sir. So that is
Yes,
one thing. Most of the journals are not free to access, so more easier access to learning material is something that should be available. Yes,
yes.
that's something we should try.
And from patient's perspective, what do you think they have asked for you most, which you didn't have the time to give them?
I think explanations. I think as long as
Uh-huh.
they're explained about what's happening, I think they're happy. Sir. They need to know what's happening.
They need to know what's happening in language that
Mm.
they can understand, be it
Yes,
Bengali, Tamil, Hindi, Punjabi, Gujarati, Malayalam,
yes.
whatever. Not English doesn't have much value at the crisis points, I have felt. Well, I think Dr. Rahman, we've been very active, and thank you, sir, for that. All government medical. You asked a question, so was that a question or was a suggestion? Because we are doing mentorship now as part of the last few minutes. Dr. Rahmanji, you want to unmute and ask, put the suggestion in audio format to the people here?
Yeah, sir, the most important requirement for now is all the medical colleges are practicing, most of the medical colleges are practicing general neurology. Because I also learned the interventional neurology in 2011. But since
Uh-huh.
then, there is no place for a proper place to start the work because most of the medical colleges are not having the subspecialty work. So we had to
Yeah.
work only in the general neurology and then you have to build up the things. So most of the corporate hospitals started the subspecialty work and that is not affordable to most of the patients unless until we do some discuss with the governments and the state government or the central
Yes.
government about this
Absolutely.
subspecialty, it won't happen.
Yeah. Well, yeah, absolutely point taken, and we have lots of changes in Bengal where I come from, and there's a major restructuring taking place in Bengal, and that could be the model for the whole of India because there's a manpower problem of doctor-patient ratio to be fulfilled. Now we are going for the next goal of putting in more specialized subspecialty neurology versus general neurology. But I think like we had a headache patient that I think fills up about 40 to 50% of any general neurology clinic. And you see what Pushkar identified there and has had a successful outcome for both mother and child. So I don't think every patient is unique. Every patient is special. We never know
Yes.
that person who is coming with a weak leg will have a myopathy or a neuropathy or something different or a psychogenic conversion disorder. We do not know, you see, and that applies across the field. So I think every patient is special. Yes, but the problem with central institutes is that they get more centralized, difficult to access. Patients have traveled so long, and we have the problem with teleneurology as well about rolling it out. So it's actually work in progress, but we need to advise our lawmakers so that the last person standing in anywhere in Bharat, hills, oceans, in the villages where I come from in Birbhum, and get not 100% of the care that you can get in Chennai or in Mumbai, but at least 95% or in the minimum 90%. Otherwise, it's not really worth having these webinars if it's for the select few. It's for the many, not the few, that we are here on a Sunday talking about people's needs from us, people's expectations from us. and how Pushkar can and his generation can achieve it for us in our lifetime, that we can congratulate them for being good sons of great fathers. Right. I don't see any more questions in the chat box, and we have, I think, a good nearly about 90 minutes, well, no, 85 minutes of very good, bonhomie and friendship and touching base with good academics, good thoughts. So if everything good must come to an end. So I'll ask Sri if you would like me to conclude, or maybe he could give in some last comments. And we haven't seen any of our office bearers, like the president or our treasurer or any of our past presidents, but if any of them are are available, I would like them to bless us by raising their hands, and Asmita ji can unmute them. So I'm not sure if Sangeeta ji, Devashish Da, or Sudhir Kothari ji, from the names I've been given, who have joined or sent links to join today, are around. Asmita ji, are any of them around? They are most welcome to give us their blessings and their last few thoughts or words. Asmita ji, any of them around?
I don't think so, sir.
Don't think so. In which case, Sri, you have the last word, and
Yes, sir.
please thank everybody and bring the session to a close.
Once again, on behalf of Dr. Parthare and myself, and on behalf of the IAN's Critical Care Neurology subsection, I thank Dr. Palani and Dr. Pushka Palani for having taken the effort for spending time on a weekend night to give us a lot of information, both medically as well as on the medico-legal and ethical aspects, which is going to benefit a lot of us. And Dr. Partha has also been doing a wonderful job as a devil's advocate in probing more questions and expanding the discussions further. Thank you very much.
That's what happens in courts. Sri, you'll soon find. I've been attending courts in some other part of the world last 25 years. It's a very hot seat, but a very good one to sit down with barristers and counsels and king's counsels as well. It's very fulfilling experience, because that's when the sharp end of neurology really comes out and you really shine. And it's nothing like shining in the West. So we should do that in India as well, because the same Supreme Court judges are asking us to give opinions which they can trust and which is proof-based, evidence-based, as I was asking Pushkar to give us. Right. Anyway, I keep coming in with my chirps all the time. Sorry for that. It's a habit.
No issues, sir, definitely. So I think with that, we can probably conclude the session. Thank you all for joining. Thank you once again, Dr. Palani and Dr. Pushka Palani. Thank you. Good night.
Thank you. Thank you very much. Thank you.
Thank you, sir.
Namaskar. Jai Hind.
Thanks.
Jai Hind.
Bye-bye.
Namaskar. Namaskar.